Welcome to Epstein Becker Green's webinar, Physician Payment Reforms, the Future of MIPS and APMs, the third installment of our Value-Based Payments Crash Course webinar series. We are pleased to have Epstein Becker Green's Lesley Yeung, Associate in the Healthcare and Life Sciences Practice, present today's webinar. Before we begin today's presentation, please be informed that today's webinar is being recorded and that participant phone lines will be placed on mute throughout the program. You are also welcome to submit questions directly to the presenter following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. At this time, I would like to turn the webinar over to Lesley.
Thank you. So the purpose of this Crash Course webinar series is to explore the undeniable trend that's happening in healthcare right now to move beyond traditional fee-for-service payment systems toward payment systems that reward value and better outcomes over volume. Today, to illustrate how Medicare payment systems are evolving in this manner, I'm going to discuss the physician payment reforms that were included in the Medicare Access and CHIP Reauthorization Act, or MACRA, a bill that was enacted in April of last year, 2015. MACRA was an impressive piece of legislation in that it was a bipartisan agreement reached pretty quickly to eliminate the sustainable growth rate formula that had plagued the Medicare physician fee schedule updates for about 13 years. In eliminating the SGR, Congress laid out a framework for reforming the way in which Medicare pays physicians. So in general, MACRA creates 2 funding streams for clinicians based on their participation in either the merit-based incentive payment system, called MIPS, or alternative payment models, called APMs. Congress left a lot of the details to CMS to figure out, which the agency has started to do in the proposed rule that was published in the Federal Register last week on May 9th. There's no way I could go through all of the details in that proposed rule today, but I am going to highlight the key components of what CMS is calling the Quality Payment Program under the Medicare Physician Fee Schedule. Next slide. We're going to start by talking about MIPS. MIPS is intended to streamline the various physician quality programs that are currently in place, including meaningful use, the value-based payment modifier, and the physician quality reporting system programs. In the proposed rule, CMS lays out the details of how these existing programs roll into the new MIPS program. 2018 will be the last year of reporting under each of these existing programs, and they will be rolled into MIPS starting in 2019. 2019 is the first year that MIPS payment adjustments will be applied to clinician payments under the Medicare Physician Fee Schedule. And a clinician's MIPS payment adjustment for 2019 will be determined based on his or her reporting and performance in 2017. So performance year occurs 2 years before the payment adjustment year. Next slide. A clinician will receive a composite score for his or her performance in 4 categories. The categories shown here in these pie charts are quality, resource use, clinical practice improvement activities, and advancing care information, which is related to the adoption and use of electronic health record technology, or formerly the Meaningful Use Program. As you can see, the weights given to the quality and resource use categories shift over the first 2 years of the program to allow for a gradual increase in the impact that resource use measures will have on a clinician's composite score. Next slide. Clinicians will receive a positive or negative payment adjustment based on how their composite performance score for each of the 4 categories compares to a base performance threshold. If clinicians achieve high performance and continue to improve their performance annually, they will be eligible for positive payment adjustments. Clinicians falling below the base performance threshold will be subject to negative adjustments. The negative adjustments are capped, but the percentages increase each year up to 9% in 2022. Positive adjustments must be paid out in an amount equal to the total negative adjustments made to clinicians. Accordingly, MACRA allows for the application of a scaling factor to the positive adjustment percentages of up to 3 times. So, for example, positive payment adjustments could reach up to 12% in 2019 and 27% in 2022 if the full scaling factor is applied. There's also an additional payment adjustment of up to 10% possible for exceptional performers. Next slide. This slide describes who is included in and excluded from MIPS. The statute defines the types of clinicians that MIPS will apply to for the first 2 years of the program and allows CMS to add other healthcare professionals starting in 2021. MIPS does not apply to certain clinicians, such as those who are in their first year of Medicare participation, those who are participating in an advanced APM and qualify for the APM bonus payment, and those who are below a low volume threshold. In the proposed rule that just came out, CMS has defined low volume to mean clinicians who have Medicare billing charges of $10,000 or less and who see 100 or fewer Medicare patients. Next slide. I'm now going to spend some time discussing APMs. If a clinician participates in what CMS has defined in the proposed rule as an advanced APM, he or she will be eligible for an annual lump sum bonus of 5%, in addition to any payment incentives that the clinician might receive through participation in the advanced APM itself. To be deemed an advanced APM, clinicians must be required to take on more than nominal financial risk, report quality measures that are comparable to the measures adopted under MIPS, and use certified EHR technology. Again, CMS has further defined each of these components in the proposed rule. Next slide. Generally, an APM is a payment model that aims to incentivize quality and value. A number of programs were listed in MACRA as APMs, including models that are being tested by the Center for Medicare and Medicaid Innovation and accountable care organizations participating in the Medicare Shared Savings Program. In the proposed rule, CMS has identified a few specific models that the agency expects will meet the requirements to be deemed an advanced APM. Notably, CMS has not identified Track 1 ACOs in the Medicare Shared Savings Program as an advanced APM because Track 1 ACO participants do not take on financial risk. CMS has also not included the bundle payments for care improvement and comprehensive care for joint replacement models in this list either. Next slide. In order to qualify for the APM bonus, clinicians must be participating in one of the advanced APM programs identified by CMS and receive an increasing share of their revenue through participation in that advanced APM. The percentages of revenue received through an advanced APM must increase from 25% in the first year up to 75% in 2023 and beyond. In the first 2 years, that revenue must be from Medicare, but in later years, clinicians can meet the threshold based on either Medicare-only revenue or revenue from all payers, as long as at least 25% of the all-payer revenue is from Medicare. Other payer revenue applicable to the all-payer threshold could include revenue from Medicaid programs and commercial payers, including Medicare Advantage plans. CMS has established a high threshold for qualification for the 5% bonus, and CMS has stated that it doesn't expect that a large percentage of clinicians will qualify for the bonus in the first few years of the program. However, CMS does want to encourage participation in APMs generally, and there are benefits built into MIPS for clinicians participating in an APM that does not qualify as an advanced APM or that does not reach these revenue percentages. Next slide. So this slide summarizes the different possible payment consequences for clinicians. On the far left, you'll see a clinician participating in MIPS will be subject to the applicable positive or negative MIPS payment adjustments starting in 2019. In addition to the MIPS payment adjustments, starting in 2026, a clinician participating in MIPS will receive a lower annual payment update than clinicians participating in an advanced APM. Clinicians participating in an APM that does not qualify as an advanced APM will be subject to the applicable MIPS payment adjustments, but there is an opportunity to receive favorable scoring under the Clinical Practice Improvement Activities performance category due to participation in the APM. There's also another possibility. If clinicians are participating in an advanced APM that does not meet the revenue thresholds that I described on the previous slide, then the clinicians can choose whether to be subject to the MIPS payment adjustments or not. And then in later years, they would be subject to the lower payment update because they don't meet the advanced APM qualifications. Finally, clinicians participating in an advanced APM are eligible for the 5% bonus, and starting in 2026 will receive a higher annual payment update than clinicians subject to MIPS. Next slide. So I've tried to explain pretty quickly, these changes to physician payments under Medicare are immense and complex. CMS is encouraging feedback and clinician participation in this payment reform process. So far, CMS has already requested comments through the 2016 Physician Fee Schedule proposed rule issued last summer. CMS also issued a request for information on MIPS and APMs last fall. Comments to those previous issuances have been taken into account in the current proposed rule, as CMS mentions them multiple times throughout the proposed rule. But again, CMS is seeking more feedback in the proposed rule, and comments are due on June 27th, so it's a good date to keep in mind. This is a good opportunity for all stakeholders to provide CMS with feedback about how the agency's proposed structure will really work, how it will change things for the way clinicians are practicing now. There are also other opportunities to shape both the MIPS and APM programs. For example, clinicians can participate in various measure development processes that will impact the measures used in MIPS. I've listed some of those here, including the Measure Applications Partnership, the Core Quality Measures Collaborative, the Annual Call for Measures, the Healthcare Payment Learning and Action Network, and the MMS Blueprint. Clinicians can also participate in the development of new APM options, such as physician-focused APMs. And there's a whole structure established in the statute for how CMS and the Physician-Focused Payment Model Technical Advisory Committee are supposed to review new APM options and certify them as viable options under the APM program. Accordingly, there are a lot of opportunities to engage with CMS, and stakeholders are really encouraged to do so to better shape how the MIPS and APM programs are implemented and how they will evolve over time. And that is the end of the content for now, so I will turn it back over to Sylvia.
Thank you, Lesley. This concludes our webinar today. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of webinar recording and access to PowerPoint materials. If you have any questions, please email Lesley directly, and her email is listed right here. And we also have 2 more webinars coming up in this series for on May 24th and May 30th. This concludes our webinar. Thank you for attending, and have a great day.